Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Exploring Current Patterns of Care in the Community, optimizing the use of oral selective estrogen receptor degraders for hormone receptor positive metastatic breast cancer. We have a great faculty today, Dr. Rinath Jeselsohn from the Dana-Farber Cancer Institute in Boston, and Dr. Joyce O'Shaughnessy from the Sarah Cannon Research Institute and the Baylor University Medical Center in Dallas. Let's talk a little bit about SERDs, and as it always is the case, we will be talking about the use of non-FDA approved agents and regimens, so check out the official prescribing information for these various products for specific more information. Here's where we're heading. We're going to do a little introduction, and this is going to be a little bit different today. We're going to focus a lot on our favorite topic and our main audience, the community-based general medical oncologists. And then we'll get into use of third monotherapy. Now we have a newly approved agents, imlunestrant. We'll be talking about SERD combinations, particularly with CDK inhibitors as an EMBER-3. And then we'll be talking about Serena-6 and treatment of so-called molecular progression. If we have time, we'll get into a bunch of other issues. But just to take a step back, as I mentioned, we focus on general medical oncologists who are not just taking care of breast cancer. They take care of, myeloma, CLL, bladder cancer, et cetera, et cetera. And really the infrastructure, what we're going to talk about today is a survey we just did over the last few weeks of general medical oncologists. This is actually before the imlunestrant approval. And I want to talk a little bit about other things that are kind of going on in general medical oncology that I thought our breast cancer faculty would find interesting. We're not going to talk about it, but I just want to sort of paint a picture of what oncologists are seeing. So Joyce and Rinath, we did this program, I think about a week or so ago on GI cancers and with Dr. Saab and Siamber. And one of the things they told us that's different from what I hear from you all is when they have HER2-positive disease and patient progresses on anti-HER therapy, they repeat the HER2 assay, and if it's negative, they don't give them HER2 therapy. I brought up that you all see it differently, but that's the message oncologists hear from the GI people. And then yesterday, I had, as always, fascinating session with Dr. Haymock, a recording session. And he was talking about HER2-altered non-small cell lung cancer, and you've probably heard about HER2 mutations in lung cancer. But what he talked about, I never heard before, which is that most of these HER2 mutations are TKD mutations. If you remember from FLT3, you have TKD and non-TKD. Most of these are TKD. And, there are two new TKIs that are very effective. When you look at the waterfall plot, these are in non-smokers. We have a new EGFR in lung cancer called HER2 TKD mutant disease that's going to really change the way we look at HER2-positive therapy. Again, we'll see whether that has any relevance to breast cancer. But I was pretty surprised to hear this from Dr. Haymock. And then finally at ESMO, we saw what we've been waiting for now since, April, when we did a program at the American Urologic Association on capivasertib in prostate cancer. We knew at that time that it was a positive study, but no details about it. But we did a CME program trying to get the urologists prepared. And of course, the GU faculty really knew nothing about CAPI, so we had your colleague Hope Rugo there appearing on video to try to prepare them for what they were going to see in this positive study. And in fact, Dr. Fazazi, who I did a video for at that time, but he wouldn't tell me any of the results, of course, presented this phase 3 study of capivasertib in PTEN deficient prostate cancer. That's what they get, deletions of PTEN. Really fascinating story. This is very different than the breast cancer story. Randomized study, incredible. They screened 6,000 people. You see PTEN deficiency or deletion in about a quarter of them, so they had 1,500 patients, and they saw a modest benefit in PFS. We'll see what people think about it. But I think the thing that was really interesting to me was that, first of all, they were really talking about this is a new subset. I mean, precision oncology is now coming to prostate cancer because what they saw in the control arm was that these people did not do well. They progressed after 2 years. They had very uncharacteristically, they have clinical progression before they get PSA progression. A lot of fascinating data. Also, it might be interesting for our breast faculty to consider. I was concerned about the glucose with them because they were given it with abiraterone and prednisone. They did see a lot of glucose problems. They allowed people in the study with hemoglobin A1Cs of 8. It's a lot higher than what it's been with the breast cancer studies. So we'll see how the urologists do if they end up using capivasertib. But before we sort of jump into SERDs, just Joyce, any thoughts about these data? You know, it's, again, we're talking about the general medical oncologist, and they're seeing a large spectrum of how people deal with targeted therapy and everything else. Any thoughts about what I'm mentioning here in terms of GI, lung cancer, and now prostate cancer, Joyce?
Well, I think the TKD story is very, very interesting because we do have these mutations in HER2 that are in the tyrosine kinase domain, but also in the heterodimerization domain. So it's really, really interesting to think about specific TKIs are going to be better for certain mutations. And I wonder about that too, even with our oral SERDs, you know, that some of our oral SERDs are going to be better for certain of these mutations than others. You know, it's interesting. I'd like to know what Rinath thinks about that because she works on that all the time. And the PTEN story here is very interesting. I'm going to be interested in seeing whether there's a survival advantage, because if you can reset endocrine therapy sensitivity by blocking this pathway, your PFS may be a bit more modest, but you might still get survival. And I can see here that they're looking at different cutoffs, you know, to see, because like everything else is a spectrum, you know, and so because it really should work. It should work. These are really PTEN deficient cancers, essentially.
So yeah, that's what I was going to ask you, Rinath, because one of the most interesting things about this is in order to get in the trial, you had to have 90% P10, but then they looked at 95, 99, and 100%. It looked like it was predictive that the patients did better with it. It was the first time I saw that type of prediction. You don't see that in breast cancer. I don't know whether you think, Rinath, in the future we're going to look at quantitative ESR1 to predict benefit of SERDs. Any thoughts, Rinath?
Yeah, I mean, this has been something we've been interested but haven't really studied. You know, is the allele frequency of the ESR1 mutations, does that really matter? You know, the ESR1 mutations, they are what we call subclonal mutations. So, you know, they're not seen in all the cells. And the question is, you know, if the allele frequency is higher, will these patients respond better? I think as we're getting these more studies and more data, we might be able to tease this out.
I also just want to mention on the P10 there, Neil, you know, they used abiraterone, which got rid of the ligand. I wonder if they had used a degrader of the androgen receptor, like an enzalutamide or something, where they would have had more, because we use fulvestrant. We use fulvestrant with capi. You know, I wonder if they had degraded it rather than just take away the ligand.
Yeah, maybe the competitive anti-androgens. Anyhow, getting back to SERDs and the general medical oncologist, so one of the things we put in our abstract we submitted to San Antonio was we asked these 50 oncologists, how familiar are you with the 12 critical, now increasing numbers with time, trials you need to know about managing people with ER-positive metastatic disease? And most of them are familiar with these trials. They want to learn more about them. But again, I think the challenge of being in general medical oncology is very evident to everybody, and it's really amazing how people are able to keep up to date. So as we go through this exercise, we're going to show you not only the results of this survey we did in July of general medical oncologists, but at the same time, we did a survey, as you can see, Joyce participated in this as well, of clinical investigators, and we'll show you how these results compared. One thing we asked them, Rinath, and here are the general medical oncologists. Everybody knows you have to get ESR1 mutation in an ER-positive metastatic disease, but the question is when? And we sort of just naively asked them the question. The oncologist said, you know, some said at diagnosis, everybody else says, you know, at second line. Same answer as we saw with the investigators. And I was thinking about the fact that actually, Rinath, now, at least in people who are endocrine resistant or anybody other than a de novo metastatic case, you're going to want to see the PIK3 to see whether you want to give inavolisib. So maybe that's part of why people get tested up front. Anything you want to say about testing for ESR1 and pitfalls that you see in doing the test and interpreting it, Rinath?
Yeah, so I mean, the ESR1 mutations, and I'll show it in a few more slides, but we really are seeing them mostly in metastatic disease and mostly after treatment with an endocrine-based therapy in the metastatic disease, and particularly after an aromatase inhibitor. So these are acquired mutations. So really from the ESR1 mutation perspective, really testing after first-line therapy in metastatic disease makes most sense. Although there is some emerging data that there could be subgroups of patients that at the time of diagnosis of metastatic disease after adjuvant therapy, these mutations can be found in around up to 15% of patients, particularly in patients who've had at least 1 year of adjuvant endocrine therapy. So I think we're going to have more data in the future to look more carefully at this patient population.
So in a second, we're going to ask Rinath. We asked both of our faculty today to do very brief presentations, and we want to have enough time to really talk about things. But I am curious, Joyce, now, again, we have the inavolisib triplet with Palbo and an AI. How do you think through second-line therapy in people who get that first line, if they're ESR1 positive, if they progress, are you going to use a SERD in that situation?
Yes, if they have indolent disease, more endocrine therapy sensitive disease, I think elacestrant is a great choice for patients. Now we have imlunestrant as another option, and I think it's probably got a little bit more activity in liver metastasis. It's got some activity in brain metastasis. We're looking forward to more data on that agent from EMBER-3 at San Antonio that's going to be of great interest. So I think there's going to be some differentiators between the two. But yes, if they're really, because I totally agree with them. Rinath, we're going to be heading towards combinations, and after progression on inavolisib and Palbo and endocrine therapy, for example, going on to imlunestrant plus abemaciclib would be great once we get access to that. And of course, the mTOR inhibitor everolimus plus the giredestrant, another nice combination, but I'm not sure I'd want to do that right after progression on inavolisib. That might not be the best timing for that.
What about capivasertib after inavolisib, Joyce?
For sure, Cappy for AKT and PTEN mutations, but now this PI3 kinase, when you got a PIK3CA mutation, the field's getting a little bit more crowded. And, it's something that, I agree with Rinath, that's definitely well tolerated. But I think that the gedatolisib is going to be of great interest as well, because it gets mTOR. So inavolisib gets PI3 kinase, but gedatolisib gets PI3 kinase and mTOR. You know what I mean? So exactly how we're going to fit in gedatolisib versus Cappy is just going to be very patient dependent, because gedatolisib's IV. So perhaps you reserve that more for your patients with heavier tumor burden, liver metastasis, and for somebody with less disease, you stick with your oral therapies. But we just don't have any sequencing data.
All right, Rinath, you prepared a few slides ago. You mentioned that the idea that we're moving towards combination, but for now, right now, we certainly have monotherapy available, and now we have two agents. Can you talk about some of the data available?
Sure, happy to. So I'll start with a patient of mine, a case. So this is a 67-year-old woman who developed metastatic hormone receptor positive breast cancer 7 years after completion of adjuvant endocrine therapy. And at the time of relapse, she presented with a malignant pleural effusion. The pleural effusion was drained, and she was started on treatment with ribociclib and an aromatase inhibitor. She did well on this for quite a while, but after 3 years on treatment, she developed progressive disease manifested with new bone metastases. So really at this point, should circulating tumor DNA testing for an ESR1 mutation be performed? And as we discussed, I'll start off just to just give some brief background about what are the ESR1 mutations. So as shown here is the ESR, the diagram of the estrogen receptor protein, and really the ESR1 mutations are all in a hot spot in the ligand binding domain, which is the domain where both estrogen binds, but also currently all our endocrine therapies bind to this same domain. And the most common mutations are in residues Y537 as well as the D538G missense mutation. And these mutations, they confer, they lead to constitutive activity, meaning they lead to activation of the estrogen receptor without the need for stimulation by estrogen. Hence the resistance to aromatase inhibitors, but they also lead to lower affinity to fulvestrant, which explains the relative resistance to fulvestrant. And what's important to remember about these mutations, although they lead to an altered estrogen receptor, they're really a biomarker of retained tumor dependency on the estrogen receptor signaling. And this is why we're seeing that these ESR1 mutations are really biomarkers of sensitivity to the novel SERDs. So where do we see these ESR1 mutations? As I mentioned, these are acquired mutations. And when we look at multiple studies testing the ESR1 mutations, both by either ctDNA or in the tumor, we see that these mutations are pretty rare in primary disease. They're also not very common at the time of diagnosis of distant metastases, and when we're seeing them is really after endocrine treatment in the metastatic setting, where they can be found in up to more than 50% of patients. And an example to that is a recent study that we published. We looked at the baseline ctDNA samples from patients from the PACE trial, which in this trial, all participants had received prior treatment with palbociclib with an aromatase inhibitor for at least 6 months. So after treatment with an AI and palbo at baseline, we found the ESR1 mutations in 54% of patients, which is similar to some of the other studies. So now going back to my patient, this patient had ctDNA testing, and this patient was found to have an E538G ESR1 mutation, so an activating ESR1 mutation, as well as an activating PIK3CA mutation. So really for this patient, having this information, we have several treatment options really based on precision medicine. We have elacestrant, which is an oral novel SERD. We also now have imlunestrant, which is the second oral SERD that was approved. In addition, the patient has a PIK3CA mutation, so this patient is also a candidate for capivasertib plus fulvestrant. So capivasertib is the AKT inhibitor, as well as alpelisib, which is a PIK3CA, a PI3 kinase inhibitor, plus fulvestrant. In addition, irrespective of the genomic profiling, this patient is also a candidate for endocrine therapy plus everolimus. So let's go into some of the data, some of the studies. So the Emerald phase 3 trial is really the trial that led to the approval of elacestrant for patients with an ESR1 mutation post first-line treatment, first-line endocrine therapy in metastatic disease. In this trial, patients who had progressed on 1 or 2 lines of endocrine therapy in advanced disease, and all patients had to have had prior CDK4/6 inhibitors. This study also allowed up to 1 line of chemotherapy. So overall, a fairly heavily pretreated patient population. Patients were randomized to elacestrant alone versus endocrine therapy of choice or standard endocrine therapy. The study had 2 primary endpoints. It was progression-free survival in all patients, as well as progression-free survival in patients with a mutant ESR1. So just briefly looking at some of the patient characteristics, majority of the patients had visceral disease, as well as 20% of patients had chemotherapy in this study. As far as results, so this is the primary endpoint, and if we look at PFS in all patients, there was a benefit for elacestrant in all patients. The progression-free survival in standard of care was 1.9 months. versus 2.8 months for elacestrant. The hazard, this was significant, although not very robust, and really where we saw the more profound difference was in the patients with an ESR1 mutation, where we saw really a significant increase in PFS with a PFS of 3.8 months in the elacestrant arm. So if we look at subgroups, and as we saw really in the previous Kaplan-Meier curves, even for patients with an ESR1 mutation, really there is a patient population that within 2 months really drop out. So there is definitely a patient population that is endocrine refractory. But on the other hand, there are patients who could benefit from monotherapy with elacestrant. And really that's the question, who are these patients? So in this subgroup analysis, based on clinically relevant characteristics, really all patients did benefit from elacestrant compared to standard of care endocrine therapy. If we look deeper into a subgroups, and this is analysis that was published last year, looking specifically at subgroups based on duration on prior endocrine therapy plus a CDK4/6 inhibitor. What they saw here in this analysis is that really the patients that derived the most benefit from elacestrant were patients who had relatively durable disease stability on prior endocrine therapy plus CDK4/6 inhibitor, and the cutoff was 12 months or above. And you can see that in this patient population, the progression-free survival on elacestrant was 8.6 months, 6 months, which is pretty impressive. And further analysis of this subgroup of patients who have both an ESR1 mutation and prior treatment with endocrine treatment plus CDK4/6 inhibitor for 12 or more months. If we look at the patients with a PIK3CA mutation within this subgroup, we see that if we compare elacestrant to standard of care endocrine therapy, there was a significant benefit. However, numerically, the PFS in this group was 5.5 months, so really less than the entire subgroup analysis. I just wanted to highlight here that looking at patients with a P53 mutation within this subgroup of patients, you can see the PFS here was 8.6 months. So really, we don't see an impact of the P53 mutations here, even though multiple studies have shown that P53 mutations are associated with resistance to treatment in hormone receptor positive breast cancer. So moving on to other studies. So the Capitello study, Capitello 291, which was the study in breast cancer, looked at capivasertib plus fulvestrant versus fulvestrant alone. And this was a positive study. Patients who received the capivasertib plus fulvestrant had a PFS of 7.3 months versus the placebo plus fulvestrant, which was 3.1 months. But I'm bringing this study to because of this subgroup analysis within this study. And again, this is a subgroup analysis, so we have to take this, we have to interpret this cautiously. But in the subgroup of patients within this study that had received prior CDK4/6 inhibitor exposure, the PFS with the combination of capivasertib plus fulvestrant was also 5.5 months. So if we start doing subgroup analyses looking specifically post CDK4/6 inhibitors, we see that probably there's not a very big difference in the progression-free survival between some of the monotherapy versus some of the combinations, but really these are subgroup analyses. So the second study that I wanted to discuss is the EMBER-3 trial, and this is the study that led to the approval of imlunestrant as a single agent for patients with metastatic ER-mutant breast cancer. In this study, patients who had recurred on adjuvant treatment within 12 months after completion of an aromatase inhibitor alone or an aromatase inhibitor plus a CDK4/6 inhibitor were eligible for this study, as well as patients who had progression on first-line treatment for advanced metastatic hormone receptor positive breast cancer with or without a CDK4/6 inhibitor were eligible for this study. And patients here were randomized to either imlunestrant alone or standard of care endocrine therapy or imlunestrant plus abemaciclib. This study had 3 endpoints, including the comparison, PFS comparing imlunestrant versus standard of care for patients with an ESR1 mutation, and then the same comparison between imlunestrant versus standard of care endocrine therapy for all patients. And then a third primary endpoint was progression-free survival for patients with imlunestrant versus patients treated with imlunestrant plus abemaciclib for all patients. So if we look at the patient population, just to highlight that 40% of the patients in each of these arms had a mutation in the PI3 kinase pathway. And then looking at the primary endpoint when we're looking at the comparison of imlunestrant versus standard of care endocrine therapy, and this is the patient population that had an ESR1 mutation. This was a positive study. The median progression-free survival improved from 3.8 months with standard of care to 5.5 months with imlunestrant, with a hazard ratio of 0.62. And then just subgroup analysis. So again, subgroup analysis based on both clinical as well as PI3 kinase pathway mutations showed that all groups did have improved PFS with imlunestrant compared to standard of care endocrine therapy. And then when looking at the entire patient population, so for the entire population, there was no difference between standard of care endocrine therapy versus imlunestrant. So we now have two novel oral SERDs that have been approved for the treatment of postmenopausal women as well as adult men for ER-positive, HER2-negative, ESR1 mutant patients in the advanced setting following first-line endocrine therapy. There are additional novel endocrine therapies that have been tested in phase 3 trials and have shown positive results. They haven't been approved yet, but we do expect that these likely will be approved. And just to touch upon some of the side effects, overall, we're seeing that these side effects are relatively, these drugs are relatively well tolerated with mostly grade 1, grade 2 side effects. So overall, from a toxicity standpoint, there are no major concerns, and we expect them to be relatively well tolerated.
So, Joyce, I'm going to show you some data from these surveys looking at how people compare the existing SERDs that we have, particularly the 2 approved ones. But I'm curious on your take. Are there any situations where you think you'd prefer one versus the other in general when you look at both what the general medical oncologists say as well as the investigators? Most people kind of, at this point, obviously there are no head-to-head comparisons, seem very similar in terms of tolerability and efficacy. Any thoughts? You were mentioning CNS penetration with imlunestrant. Any situations where you might prefer the newly approved SERD?
Well, imlunestrant is a pure antagonist. The elacestrant has some agonist-antagonist effects. I think elacestrant's a great choice for your endocrine therapy sensitive patient, bone only, lymph node, lung, good amount of time on prior CDK4/6. When they looked at the prior CDK4/6 duration in the EMBER-3 trial, they found the imlunestrant was superior to the fulvestrant regardless of the amount of prior time on the CDK4/6. So even patients who had progressed pretty quickly on their CDK4/6 benefited from the imlunestrant. Again, a little hint there that maybe that pure antagonism is a little better for maybe a little bit more endocrine therapy resistance. And like the forest plot that Rinath showed in liver, it was quite effective in liver. And with elacestrant in the Emerald trial, we've seen visceral disease. They didn't have enough liver patients to give us a separate analysis of liver. And we also saw progression in brain with the development of brain metastasis was less in the EMBER-3 trial with imlunestrant compared to fulvestrant. So, I think there's a little hint there that maybe for patients are a little bit more both endocrine therapy sensitive, but also endocrine therapy resistant. We haven't seen final survival yet on EMBER-3, so we look forward to that. Whereas we have on the Emerald trial, and there's not a survival advantage with elacestrant. So we'll stay tuned.
So I want to show you some of the ESR1 mutant scenarios that we presented. But Rinath, as you were presenting your 67-year-old lady with double mutant, ESR1 and PIK3, Danny in the chat room has an 81-year-old woman with recurrent disease after being on adjuvant and anastrozole for 4 years. Patient has ESR1 and PIK3, in addition to RB loss. PFS is 2. He wants to know what your recommendations are for a patient like that with this double mutation. Before we get to that, though, let's take a look at the scenarios we presented in terms of single mutations with ESR1. So, Rinath, when we present a 65-year-old woman, been on a CDK 2.5 years, ribo and letrozole, and the general medical oncologist, almost all of them say elacestrant. Incidentally, they've used on median of 4 times, they've used elacestrant. Oncologists use new drugs all the time now in all their cancers. We also saw in the investigators, same scenario, 2.5 years after being on CDK, again, ESR1 mutant. But now we put in a situation where the patient has visceral mets, although normal LFTs. The general medical oncologist is still saying elacestrant, but now you see the investigators pulling back a little bit, thinking more about either a BEMA with fulvestrant or an ADC. Any thoughts, Rinath, about, and here's here we have an 80-year-old. This is more like Danny's patient, and with minimally symptomatic bone mets. Now, when you look at particularly the investigators, you see, mainly, I guess, because she's older, even more of a move toward elacestrant. And I guess, Rinath, we can talk about efficacy, but also I think you could, indirectly say that SERDs are going to be a lot better tolerated than PIK3 drugs like Capi. Any thoughts about these mono or, ESR1 mutant PIK3 wild type or non-mutated patients for now?
So I think I would, for patients that have had really that show that they have endocrine sensitive disease, I would favor those are the patients that I would go with a monotherapy elacestrant. So really, I do think that using this duration on prior treatment with a CDK4/6 inhibitor plus endocrine therapy is a helpful clinical marker to identify those patients that have technically endocrine sensitive disease, where elacestrant or imlunestrant could be a good option. Also, if they don't have a PIK3CA mutation, there's data that they are more likely also to benefit from a single agent endocrine therapy, and that's another criteria to look at. And then again, it's important to see, how much disease does the patient have? How symptomatic are they? Is there visceral disease? If there's significant visceral disease, symptomatic visceral disease, I think a single agent, I'm less likely to choose a single agent endocrine therapy.
So, Joyce, in a scenario that we've seen a lot of variability in how people respond, particularly depending upon the cases, the patient with both ESR1 and PIK3, like Rinath's patient, I didn't ask you why you preferred elacestrant, but it looks like it's, your colleagues in the survey said the same thing about the same scenario. Joyce, what about the double mutation patient? Well, we saw data there with elacestrant and imlunestrant looking at patients with not only ESR1 but PIK3, but I'm not sure there's data with capivasertib in that double mutated situation. Here's the way the general medical oncologist, we present a patient who's been on 2.5 years, minimally symptomatic bone mets. Again, the most common answer being elacestrant. I'm sorry, I went hold on, let me see here. Sorry, that was the 80-year-old. I was 65-year-old with the PIK3. You have actually a split in the general medical oncology between capi and elacestrant. When you go to the investigators, you see more elacestrant. Again, I don't know, maybe that's because it's better tolerated, maybe because they have data with double mutations. Here's another, any other thoughts about double mutated patients, Joyce, and how you make a decision there?
Yeah, I think both of these top choices would be what I'd be kind of offering and talking to the patient. I think that after progression, it's 5.5 months for probably both of these options, truthfully. And I think that going with, if she's minimally symptomatic, which she is, I probably would go with the least toxic approach, which is the elacestrant. You can always come in afterwards with capivasertib. You can give capi and fulvestrant afterwards. We probably will get more options here in the near future with giredestrant and everolimus and the PI3 kinase mTOR inhibitor gedatolisib with fulvestrant or a triplet with palbociclib. So we're going to have a lot of options, but I probably would go with elacestrant and then maybe go to fulvestrant and capivasertib based on what we have in hand today in a minimally symptomatic patient.
So, of course, we're getting a lot of questions in the chat room about the combination of imlunestrant and abemaciclib, or can you use it? I mean, they're both now approved, although I don't know that there was any comment about using with the CDK and the FDA approval. But let's talk about this combination arm. Here's a New England Journal paper on the EMBER-3 study. And again, in the combination arm, again, to single agent, you saw a distinct advantage there now with a PFS of 9.4 months, including in patients who previously received a CDK inhibitor. You're kind of like adding in SERDs to the post-monarch strategy of abema after prior CDK. And this is from the discussion from Dr. Burstein, your colleague at Dana-Farber, Rinath, where he puts up this slide and he said, I know I'm not supposed to do this, but here's an indirect comparison. And over there on the right, you see the combination arm from EMBER-3 with a more than 9 months PFS that he noted, and I think everybody else did. Just again, in keeping with the complexities of oncology nowadays, here's his algorithm. I'm not even going to attempt to go through it. We're trying to hit on different parts of it here, but obviously this has gotten very complicated. So I guess one question is sort of obviously after this, Joyce, is how do you all feel about using the combination of imlunestrant and abema? Here's what your colleagues say. So general medical oncologists, we asked first and second line. More than half say they'd want to use it first line, and more than 2/3 say they will use it second line. When we asked the investigators, actually 80% say they would consider it first line, and all would use it. So basically, they all of your investigators, so all your colleagues want to use this combination. You can tell me whether or not how easy or challenging that might be to actually do right now. We also asked whether or not the people would use another SERD with a CDK in the sort of EMBER-3 strategy. Most of the general medical oncologists say no. Same thing, although a little bit more split with the investigators in terms of substituting. So Joyce, what's your take about the strategy of SERD plus CDK, and specifically the EMBER-3 strategy of abema and imlunestrant? How would you like to be able to use it? And right now, how can you use it?
Yeah, I think it's limited being able to use it right now, Neil, without the FDA and the NCCN guidelines endorsing it. Because there are still two drugs and neither of which is generic at this time. So I think it's still challenging, but I think we're all really wanting to use it under multiple scenarios. I mean, if you see an ESR1 mutation in your first line patient, then you're going to want imlunestrant and you want a CDK, so you want that doublet there. If somebody progresses on first line AI plus palbo or ribo, and you've got your second line choice, we know that the imlunestrant abema works regardless of PI3 kinase mutation status, for example. And so that would be a great strategy for second line, regardless of ESR1 mutation status, regardless of PI3 kinase mutation status. And we're all very familiar with that. We can always inhibit the PI3 kinase pathway next, if you will. So, I think particularly compelling when we see an ESR1 mutation and we want combination therapy, and abemaciclib, kind of it's downstream from so many mutations, that it is just, you give it with a oral SERD, and you're going to inhibit so many different pathways, regardless of the mutations or wild type. So I think it's we're very much looking forward to getting FDA approval of that combination.
So Rinath, I always love talking to you about mechanisms, very few of which I can understand, but any thoughts about why you would see benefit to a second CDK inhibitor, CDK after CDK, and whether any thoughts about why there might be some synergy between CDK and SERD?
Yeah, so I think one thing we have to remember that, not in my opinion, and I think there's quite a lot of evidence that, not all CDK4/6 inhibitors are equal. And abemaciclib particularly, the early studies did show that it has other activities. So it does hit CDK2, it does hit CDK9 slightly. So I think it has less selective activity, and that might also be why we're seeing this benefit of abemaciclib post-palbociclib, both in, the post-monarch, and now we're seeing that in EMBER-3. I wonder, is there some specific particular synergy between abema and a SERD that's different than abemaciclib plus other endocrine therapies? I think we don't know, but certainly the data from EMBER-3 is very, very impressive. Really nice response benefit from this combination post a CDK 4/6 inhibitor.
So let's talk now about the use of SERDs. For the first time I heard the terms molecular progression was actually in the discussion by Dr. DeMichel in the Serena-6 study, but she calls it molecular progression, although I'd say it's maybe resistance progression. But anyhow, Joyce, let's talk about the data, and then after that, we'll get into what it means.
Okay, yeah, I'll briefly recap here, Serena-6, see if I can get this to go ahead. Perfect. I'm going to start with the case of a 44-year-old woman who presented with an enlarging right breast mass and axillary lymph nodes, and biopsy was grade 2, invasive ductal, ERPR strongly positive, HER2 negative, high key 67-30%. PET scan shows multiple bone mets and liver mets, mildly elevated LFTs at presentation. She's asymptomatic. Biopsy confirms the same. ctDNA NGS show bad stuff with co-amplification of FGFR1 and cyclin D1, a real luminal B scenario. And panel testing shows no germline mutation. So she's treated with leuprolide, letrozole, and abemaciclib. PET scan shows resolution of liver mets, but low amount of residual FDG uptake in bone lesions. Now she continues on therapy, and per Serena-6, she starts serial testing for ctDNA, specifically looking for an ESR1 mutation every 3 months. And after 16 months on her triplet therapy, she has 2 ESR1 mutations that are found, but PET scans repeated and it hasn't changed. She's still got this low level activity in bone metastasis. So her therapy is changed to leuprolide, abema, and she switches from AI to camizestrant per the Serena-6. So we know from Paloma-3 up at the top that with fulvestrant and palbo, if you've got an ESR1 mutation in red, you do more poorly with this combination than if you have wild type. And then down the bottom, if you look at the red and the purple lines, the bottom 2 lines, you see that the bottom line is fulvestrant alone in the ESR1 mutant, and the red is adding palbo. So palbo works, but it's not nearly as good as wild type. So over on the right, my conclusion is that when it comes to ESR1 mutant breast cancer, we need an oral SERD, and we need to be able to combine that with other agents like CDK4/6 inhibitors, because these patients simply do more poorly. So we got to think about targeting those ESR1 mutations, even in patients whose disease is not yet clinically progressing. And that's what the PADA-1 trial did. So ESR1 mutations they're acquired, as Rinath said, in patients, particularly on the aromatase inhibitor. So PADA-1 targeted patients with a rising ESR1 mutation status, that they found them, they became detectable, and then they scanned them to make sure their disease wasn't progressing, because they were all on an AI plus palbociclib. And then they found the ESR1, they scanned them, they were not progressing, and they randomized them to stay on AI palbociclib or switch over to try to go after, as best they could at that time, the ESR1 mutation with fulvestrant plus palbociclib. And then the patients who eventually clinically progressed on AI palbociclib were offered the option to stay on palbo and then switch over later onto the fulvestrant. So there was a crossover there. And so what they saw was a 7-month improvement in PFS in favor of switching from the AI to fulvestrant when they found the ESR1 mutation. So that was statistically significant. And those curves are pretty impressively apart. And then they had 49 patients on the AI palbo arm who progressed and who then went on to get fulvestrant palbo. So it was a subset of the patients, not everybody, but a decent amount. Now they were crossing over at clinical progression, and the PFS was pretty lousy at 3.5 months. PFS2, adding together the first PFS with the second PFS, also was really greatly in favor of switching patients over to palbo fulvestrant, 29 months versus 14 months. And again, you see the curve over there on the far right, this 49 patients who waited till clinical progression, stayed on their palbo and switched over the endocrine therapy, basically had almost no benefit whatsoever. So switching at the time you found the ESR1 mutation before clinical progression gave patients a lot more benefit than waiting to do the same until they had frank clinical progression. They looked in PADA-1 at how long patients stayed on if they cleared their ESR1 mutation. So in the swimmer's plots, the light green is patients who cleared the ESR1 from their bloodstream. You couldn't find it anymore. And you can see if they cleared it, they stayed on longer. On the x-axis is how long they were on therapy. And so you can see patients who cleared their ctDNA did better in the Kaplan-Meier plot over there for PFS than those who did not clear it. So really, it was still driving resistance. If you didn't clear it, the patients, it did drive resistance. So that led to the SERENA-6 trial, the plenary presentation at ASCO this year. For patients, again, they were getting AI plus whatever CDK4/6 the physician recommended to them. They had to be on at least 6 months and benefiting. And then they started ESR1 mutation testing. And they found it in about 300 plus patients, and then they scanned them. When they found it, they scanned them to make sure they weren't progressing with their metastatic disease. If they were still benefiting, no progression, 315 patients were randomized to stay the course on their AI plus CDK or switch over to the oral SERD, camizestrant, plus their same CDK4/6, and the primary endpoint was a PFS. And you can see in the top right, the investigator assessed PFS. There was a 6.8-month improvement in progression-free survival in favor of switching to Cami when that ESR1 mutation was found versus staying on the AI. And PFS2 bottom right is immature, but we can still see those curves are splitting towards the end there. And then bottom left was the PRO data, the patient reported outcome, time to deterioration in global health status, quality of life. And you can see in the darker line in the patients who stayed on their AI plus CDK, there was this steep drop off in their quality of life. Whereas in the patients who switched over to Cami, there was a much less a deterioration of their quality of life. And that was a little puzzling to us because it was that steep drop off in quality of life. But if you look at the shape of the PFS curve in patients who stayed on AI plus CDK, there's not that same steep drop off. So how could there be so much difference in, with lack of clinical progression, but you're still seeing this major drop off there? And so at ESMO just a couple of weeks ago, we saw a breakdown of the quality of life data. And you can see on the left pain. So these patients really developed a lot more pain in the they had a lot more pain in the AI palbo arm, and the green line, those who switched over to Cami did not. So it's, now Erica Mayer presented these data, and she said she didn't think it was due to the fact that some patients stopped their AI and their joints felt better because they had been on their AI a median of 2 years. And she said the arthralgia amount was about the same on both arms. And so she thought there might be some more subclinical progression that had been going on with these patients, and they were starting to get a little bit of bone pain. That's what she thought. Fatigue, you can see there, but look at that shortness of breath and dyspnea on the right. Now, that's clearly a cancer-related deterioration. So it made a big difference there, as you see, switching over to the Cami. And then, for example, emotional well-being on the right, and role impact, your functional status also was in favor of switching. But I think the pain and the shortness of breath really did speak to more in the way of subclinical tumor type progression in patients who stayed on their AI plus their palbociclib. And that kind of makes sense because we know the disease kind of does progress slowly, sometimes before you can even see it on scan. So this is a schema that Angie D. Michel presented in her discussion. And you can see on the right there was a 6.8-month improvement in PFS switching, 16 months versus 9.2 months. So patients who stayed on their AI CDK got 9.2 more months. But if they switched, they got 16 months. But here's the thing. In the Serena-2 trial, patients who got single agent Cami after progressing on AI plus CDK, they had 5.5 months. So if you add the 5.5 to the 9.2, we've only got about 1.3 month difference in the strategy. So that's really the question: is why not just continue the patients on their AI CDK? And then at clinical progression, give them Cami. Then what about that? And don't know the answer from this trial because patients were not crossed over to Cami and they didn't have access to an oral SERD. So we don't have that crossover. But I just want to point out some of my own thoughts here. In Serena-6, ESR1 mutation detection occurred between 4 months to 8 years after initiation of AI plus CDK. So because you could start your screening at any time. As long as they hadn't progressed, you could start your screening at any time. And patients have been on a median of 2 years. So my question is, if we had found the ESR1 mutants sooner, before we had all this subclonal heterogeneity and all this stuff, would we have seen even more benefit from switching to Cami? And my answer is probably yes, because all of our therapies work best when there's the most minimal amount of disease that we possibly can treat. We know, for example, in the red box that after progression on an AI, that sometimes you find a single ESR1 mutation and sometimes you find polyclonality, multiple. And we know from the Serena-2 trial, now this is not seen across every trial, but we can see in the Serena-2 trial here that the median PFS with a single ESR1 mutation was 12.9 months, and it was 4.7 months with polyclonal, suggesting you'd like to find this ESR1 mutation earlier before there's a whole ton of these things to actually cause resistance to your SERD. You want your best efficacy from that oral SERD, find it early. And plus the fact, look at these orange bars. This is after progression on AI and CDK. All this stuff comes up. A lot of these luminal cancers are driven by APOBEC carcinogenesis, and they're constantly making more and more point mutations. And you get a lot of other genomic alterations coming up over time. And I think if then you're asking your oral SERD to do a lot, you want it to go after that ESR1 mutation, which is one of the, a very prominent, dominant mutation that comes up when patients are on AI. So I think the sooner, the better. And so the question is, if we can find this mutation as soon as we can find it at the ctDNA genotyping limits of detection, at that very earliest sign, can we then drive that thing down better than waiting until it's way up there, years and years and years and years after they have been on their therapy? And I think that's a really interesting question. So my conclusion is that early treatment with an oral SERD to inhibit the driving mutant ESR1 that is causing that AI resistance, early treatment is likely to be better than waiting. Longer AI therapy leads to acquired polyclonal mutations and a lot of other molecular alterations. Longer AI therapy, you get more acquired aggressive mutations that are acquired and more resistance mechanisms. So the earliest detection of ESR1 mutation with the lowest metastatic and mutation burden with an early switch to the AI and oral SERD, I actually think that's where we're headed, to be honest.
So I want to just close here by showing you what we found in these two surveys about clinicians' thoughts about whether or not they feel the data there is adequate to bring it up to a patient, and in some situations use this strategy. I think this is maybe the most interesting thing that we saw, because I think Dr. DiMichele, you kind of came away from her talk saying we need to wait a little bit, and I was kind of getting that impression talking to other investigators. But here's what happened when we asked people, is this sort of ready for prime time? First of all, when we asked the general medical oncologist about the Serena-6 strategy, actually 2/3 of them said, yeah, they want to use the strategy. But then when you ask the investigators, you see most of them say no. And we had a couple of investigators who are writing a paper, they're trying to include our data. They concluded, well, it's not ready for prime time. And then I was saying, well, 7 out of 13 is not like 19 out of 20. It looks like there are a significant number of people in both groups, but particularly in the general medical oncologist, who would like to at least present it to patients as an option and maybe involve them with the decision. And we gave specific scenarios: a patient who's found to have ESR1 mutation after 1 year. And again, with the general medical oncologist, half of them would like to switch with camizestrant. When we asked the investigators, most of them would not do it at 1 year, but then we go to 2 years. And again, 50-50 with the general medical oncologist. But also you still see a number of investigators who say they like to do that. Some pretty prominent people that were among those 7, actually including you, Joyce. So Rinath, I'm curious what your thoughts about this. There are financial considerations obviously as well. But I guess my question would be, you might have a patient who's a medical oncologist. If they know the data, they'd like to get treated early. If you could, would you do it? Do you think this is an option that maybe should be considered at this point?
I would say it's not ready for prime time yet. I think we do need to see more PFS2 data. It would be nice to have a crossover. But I think the data is very compelling. I think it's just not ready yet. We need a little bit more data.
So one final real quick question back to you, Joyce. We also saw at ASCO present phase 3 data on the PROTAC vepdegestrant. Kind of looked pretty similar to what we saw with SERDs. Dr. Hamilton did a program with us. She said she thinks maybe it's a little bit less toxic, but SERDs are pretty non-toxic. Do you think there's a future for this PROTAC, Joyce?
I do. I'll tell you, first of all, it's very, very well tolerated. And I think I want to see what I didn't point out in that Serena-2 data that I showed you with the ESR1 single versus polyclonal, is that there's also this analysis of the Y537S, and it's really active. It's got a huge long PFS, and then they got the 538G, and it's shorter. It's a shorter PFS. Now, the confidence intervals are this wide around those data, right? But stay tuned, right? There may be non-cross resistance. There may be, I don't know, Rinath, you're the expert here, but you think some of these things may have different activity against different mutations?
It could possibly be. We don't really know yet the structure exactly of these drugs in the LBD, how it changes the ligand binding domain. But clearly, the chemistry of these drugs are different, and they might be causing something different. So I think, we are going to need to learn what, is there cross resistance? Can we treat them sequentially? Potentially, what are the mechanisms of resistance to these novel SERDs, and how can we tackle them? So I think there's going to be a lot that we're going to need to learn.
So another general medical oncology alert. I'm hearing there are going to be a lot of very interesting BTK, Bruton tyrosine kinase degrader papers at the upcoming ASH meeting. So we'll see whether or not BTK degradation has a future in CLL and maybe other diseases. So Rinath and Joyce, thank you so much for working with us today. Audience, thank you for attending. Be safe, stay well, and have a great night. Thanks so much, Rinath. Thanks, Joyce.
Thank you, Neil.
Thank you.
Have a good one.
Good to see you.
Have a good
See you
night.
both. Bye-bye, guys. Bye-bye
Bye.
now. Bye-bye.